I will be moderating this session. As a faculty member with the Health and Exercise Science Department, many of my courses involve health sciences and public health issues. During my spring semester, one of my courses led students to work with infectious disease and followed this COVID-19 virus from the very beginning until about May. And I think it's safe to say that none of us would predict where we are today with this virus. Our speaker today, Bill Whitmar, has been at the front line of this life-altering virus. As the Public Health Laboratory Director with the Department of Health and Senior Services in Missouri, Mr. Whitmar has overseen the safety training and protocols related to the accurate and safe testing for Missouri. He currently also serves as the president for the Association for Public Health Laboratories, which is an international organization that oversees the global quality service. Mr. Whitmar brings over 30 years of experience in public health, and I'm so excited to have him here today to speak with us. His session today, the COVID-19 pandemic response, will share stories from those who live it daily and how we can continue to move forward through the impact of this virus. Your microphones are going to be muted for the session today. However, I encourage you to use the chat feature throughout the session. We will have a question and answer session at the end of his talk. Our session today will last from 10:30 to 11:30. And without further ado, please welcome Bill Whitmar.
Well, thank you, Amanda, and welcome to the symposium from Westminster College in Fulton, Missouri. It's been my pleasure to have worked with the administration there at Westminster College for the last couple of months, trying to craft this presentation on COVID-19. Initially, as I spoke to the people here at Westminster College, I thought this would be a great, quick and easy presentation about this COVID-19 because it's been in the news. We work with it daily here at the State Public Health Laboratory in Missouri. But you know what? It's not that easy because there are so many different aspects to this disease, to this virus, to this laboratory issue, to this infectious disease issue, to this issue worldwide. The presentation that I was developing adapts. It gets bigger. It gets new. It's just so different all the time, and it just wasn't as easy as I thought it was going to be on the onset of this offer, gracious offer that they made to me. So it's just like the disease itself as it evolves over time. So did this presentation. So I hope that what this gives you is some insight. And not only to the disease, but to the response effort by the federal government, by the state governments, local governments, but also by the laboratories throughout the states and the maybe to the global issues as well at those laboratories. So we're going to share my screen and to the presentation as it begins. So the title is the COVID pandemic response, the story from those who live it daily. So those who live it daily from my perspective, from the perspective of those I work with, are the laboratorians, the people that work downstairs. I'm speaking to you live from the Missouri State Public Health Laboratory, which is a beautiful facility. Like most state public health laboratories in the United States, we're more modern in the last 15 years than they had been historically because of the influx of a lot of federal funding to take into consideration the bioterrorism, the chemical terrorism events since the most recent anniversary, unfortunately, of 9/11. That brought in a lot of federal funds to modernize the state public health laboratories. But as it pertains to the topic at hand today, and what's in store for you today, we're talking about the genesis of this COVID-19 response, the challenges that the state public health laboratories and laboratories in general, I guess, commercial labs, university labs. We'll talk a little bit about the successes that we've been seeing, and those successes are more recent, but there have been successes as we go along in this response. And then the current status what we see in the September of 2020. And then some perspective is, why couldn't you guys do better? And you guys, who are you guys? The statement could be declarative as the state public health labs or the federal government or state government, but I'm going to take a little wider purview on this. You guys, I'm going to say as society, human beings in general, I think. And then a short perspective is, what does the future hold for us? The future, maybe in the short term, maybe longer term. So we'll bring all these aspects into the presentation. So SARS-CoV-2, that's the COVID-19, the virus that causes the disease COVID-19. As this presentation began, the January and February timeframe is when we thought that the SARS-CoV-2 virus came into the United States. But you've seen some presentations and some publications that say maybe it arrived in the United States a bit earlier, maybe as early as December in California. But they arrived from China and into Europe, into the United States. And the Centers for Disease Control and Prevention, the laboratories in those facilities in Atlanta began to respond to this epidemic. And as I have in parenthetically, note that term, epidemic. They began to respond in February by developing a SARS-CoV-2 assay. That's the more technical term for a test. And those tests should be rolled out to state public health laboratories. So those first cases, those were sporadic cases in California, Washington, and New York. The Washington cases were pretty famous initially because those cases in Washington were in nursing homes. And nursing homes have been epicenters for this COVID-19 outbreak, pandemic, and epidemics throughout the nations since then. So as I mentioned, the long-term care facilities, cruise ships, returning vacationers from Europe particularly, and I mentioned airports too. Airports were essentially breeding grounds for COVID-19 cases. If you've ever been to an airport coming back from overseas, you know that there's long lines, people packed together, going through customs, going through awaiting luggage and things like that. So that's a great place for viruses to mingle amongst individuals. And then the epidemiologists, those people that investigate disease outbreaks, laboratories and clinicians around the world are getting ready to see what's happening with this COVID-19, at that point, epidemic. Then, they're beginning to be overwhelmed, particularly in China and Europe. When I say overwhelmed, who's being overwhelmed? It's the hospitals, it's the public health officials. The hospitals are having diversions. And when I say diversions, they're saying a hospital A has too many patients, and the incoming patients have to be diverted into another hospital. There's just no more capacity within some hospitals because there's just too many patients. There's not enough facilities within some certain hospitals. So in March, this begins to get really serious. The case counts increase worldwide. The medical facilities, as I mentioned, are on diversions in Europe, and particularly in Italy. WHO is what the WHO means, the World Health Organization, considers a pandemic classification. And quite frankly, they probably took a little bit more time with this than during other pandemic classifications like the H1N1 or the swine flu back in 2009. We're a little bit uncertain as to why they took a little bit more time to consider pandemic classification. And a pandemic is when there's a widespread outbreak of a certain disease outbreak, when it crosses international boundaries and becomes really worldwide. And the cases increase in the United States beyond those initial cases of Washington, California, and New York. And really, they're still sporadic. They're not really widespread in every case. And like in Missouri, we hadn't really had a single case in this particular time, maybe one or two. The state public health laboratories, of which there is at least one in every single state, the CDC encountered problems with the initial CDC test. The test, as you see in the upper right, is a PCR, polymerase chain reaction test. What that basically means is that when you have a specimen sent in from a patient, there may be a viral particle or viruses from that particular patient, the polymerase chain reaction test will amplify or multiply the amount of viral particles in that test up to a point where an instrument can detect and report that there is, in fact, in this case, COVID-19 viruses within that patient. But there were, in this case, problems with that particular test. And we hadn't really encountered that in past outbreaks or epidemics from CDC. But because this was a worldwide problem and they couldn't identify what the problem was with this test, the last bullet point was, yeah, this was a big we couldn't then determine what the problem was. CDC couldn't determine what the problem was. And since the state public health labs absolutely rely on the CDC assay or test to provide testing for their states, we have a problem. And that problem was that we couldn't determine the scope of COVID-19 within each state. So the second bullet point here, the sub-bullet, is the apparent prevalence of the disease somewhat diminishes the impact that we being public health, can mitigate then the COVID-19 response in our states. So basically what that says is if we can't tell how much COVID-19 there is in the state, then we can't say we need to take these public health measures to minimize the amount of COVID-19 in the state. That's a problem. But some states did take action and they said, we're going to take other tests, we're going to develop our own tests because they have unique capabilities. The state of New York is one of them. They have what is termed a mini CDC in the state of New York. They have vast capabilities at the Wadsworth Center in the state of New York. It's a beautiful laboratory. They get hundreds of millions of dollars every year to develop their vast capabilities there. So within the state of New York, we began hearing things like, everybody gets a test. Boy, that's somewhat scary. And I'll tell you why. Because this next slide shows a couple of things here that begins to outlay the problem with that everybody gets a test. First of all, Italy is undergoing just an unbelievable amount of case count for COVID-19. They're one of the countries that is having the hospitals overwhelmed with the number of cases, and people are this country is shutting down. And in particular, Milan, Italy is being shut down. Well, what is wrong with that from the standpoint of public health? Milan, Italy is the producer of the most number of swabs, those little things that get stuck into everybody's noses these days. So without having the capability of producing swabs globally, then we're having problems. Shortages of the supplies meant to test people worldwide makes that this third bullet point, everyone gets a test, a problem. So do we have the infrastructure in place now to ensure that everyone gets a test? Maybe we shouldn't be saying that at this point in time before we know whether or not we can provide that. So now what? The labs are being instructed by different entities, they're governmental overlords, to provide a test to everybody. How do we adjust, adapt, and overcome to this? So the state public health laboratories are directed to provide the services. So what we do in times of these situations is that we have this network, and this network is the Association for Public Health Laboratories, of which you heard Amanda say that I'm the president of. So we have the ability to say to Wyoming, if you're not having any COVID-19 cases at this point in time, you have enough material to share with other laboratories. And Missouri is one of those states that we had few case counts that we could share, Wyoming could share. And so that's what we did. The federal government at the same time is making some attempts to overcome these shortages as well, but it does take time to ramp up some capacity to provide some of these shortages for media, and I'll talk about media in a minute, and also for swabs. But the bottom line, as in the slide, we are on our own. And that is a scary situation for states who have little resources at this time because we're all still ramping up. So April and May, we all decided, the states decided that we should be more realistic about this. So the testing is cut back to only those individuals who are symptomatic. That's a bit of a difference from everyone gets a test, where everyone could be asymptomatic, or people who are really worried that they have the disease, or they just want to ensure that they don't have it. So we're cutting this back to those people who are symptomatic, and the supplies are apportioned to those in need and shared between states and labs. So those states and laboratories that are really desperately in need of the supplies, New York City is one, California, Texas, Arizona, Florida, those supplies are apportioned to those states. Also, we are all looking at since I said we're on our own, how can we work better on our own? So we all start looking at things like 3D solutions. SWABs are basically a nylon or rayon flocked swab end on a stick, and not a paper stick, but a rayon stick. So that's all plastic stuff or synthetic stuff. So maybe we should be looking at a 3D printed solution. And so we all did that, but they were expensive and they can't be mass produced to the tune that we all required. They could be produced for hundreds a day at different universities or academic institutions, but we're looking at needing tens of thousands per day. But we are looking into that, and we did at that time. And similarly, our partners overseas in countries like Korea and China have really ramped up production and begin to send some of those supplies over to the United States. Now the federal government has supplied contracts to a couple of United States suppliers, and those supplies begin to come to the states. But those supplies are very low in quality and sometimes just not usable for laboratories and for medical solutions. This shows what we absolutely need to have, ideally, to collect COVID-19 or any other respiratory pathogen from a human being. The bottom swab is one that's has not been used at this point in time. It's a synthetic, made of synthetic material. We can't have organic material for PCR because that would maybe amplify some other DNA material from the organic material. So these are all synthetic, and notice that they are individually sterilized, packaged, and there's a break point in the middle of that picture. That's a reason for that break point that I'll explain in just a minute. So this is a great example of what we would really ideally like. This is an examples of media. The media is a liquid in a tube, and that media is a food for the viruses. So once you get a swab, you put the swab in the tube, you seal the tube, and that media keeps the virus alive until that virus and tube can be received by a laboratory for testing. I want you to pay attention to that top tube. We'll visit that top tube in a little bit, but these are examples of the kind of media that we've been receiving over the last few months. This is an example of some of the swabs we received from the federal government initially, notice that there's no break point in this swab. It's synthetic material, that's suitable, and it's individually and sterilized and wrapped. So that's all right. And so these are examples of how that last swab is longer than the media tube, but there's no break point. So the reason I bring this up is that when you are in a mobile collection site, like we've heard many thousands of times in the news, where there's miles of waiting for people in their cars, the problem with that kind of that swab is that it's hard to break off in half and stuff inside one of those media tubes. So there has to be a scissors to cut it off and put it in a media tube. And then the problem might exist where that scissors sterile and maybe contaminate the tube and the swab and then again the specimen. We don't want to have contamination or potential contamination between samples. That could lead to a false positive between specimens and patients. So that's a problem, potentially a problem. And to wiggle that shaft back and forth, which I have done numerous times, might take you upwards of 40, 50 seconds to break that shaft to a suitable length to put into the media tube. And that's just a lot of time if you're spending 12 hours a day in a mobile collection site when you're adding 40 seconds with every single sample and you're testing thousands of people. It's a problem because of it's a function of how many people you're testing. Now, the small little swab there at the top, I'm going to mention now. We received hundreds of thousands of these swabs. Initially, we received the boxes of swabs. They were labeled as cotton swabs. We absolutely cannot use cotton swabs. But the manufacturer said, oh, wait, they're not cotton. They are synthetic, we promise, and we'll send you a letter that states that they are not cotton. Okay? But the other problem is that was a box of 170 of those swabs, all within the box and not individually wrapped. So they are not sterile, which leads to a contamination problem or potential contamination problem. But still, we began to receive more and more of those swabs. In the second photo on the right, they just changed the box to get rid of the cotton designation. So now it's just a plain box, but they are still containing 170 swabs with no individual wrapping for those swabs. So we prefer not to send those out to be used for testing unless we absolutely have to. We're running out, then we might have to send those out, but they're just not suitable for testing for COVID-19. Now, I told you I'd come back to this media tube here. This media tube looks different, significantly different than other media tubes, and we wondered why. Within a week, we were told not to send these out because there was a problem with them. We were not told what the problem was. Only later did we find out they were contaminated. Why were they contaminated? Because this company received a federal contract for media. It was a small little company in a state, and this tube is actually a slug, and but I mean slug. It's a plastic precursor to make this. This is a 2-liter bottle that you commonly find in soda, and this company actually just decided that they were going to use this slug to put in media and make a cheaper product for laboratory testing. But this is exactly what that product is used for. So anyway, we continue. In May, because of behavior modifications as dictated by different governments, different levels of governments, we had shutdowns, we had the mandatory sometimes use of masks within the states. The supply situation improves, we get better swabs, we get better media, we get more media. As you notice on the right, there's a picture of our warehouse. We had many pallets full of supplies. And the new role that we had in our laboratory was not just to get stuff for ourselves and to test all the specimens that come in, but we actually are now working with commercial labs, academic labs, within our state, and other labs are doing the same within other states. So our staff aren't just doing things for ourselves anymore. We're doing things for every laboratory in the state of Missouri. That's fundamentally a different task, a different role for us and for other labs across the nation. So we have to do more with the same staff levels that we have in our laboratories. But get back to our behavior modifications within the state. What's this leading to is daily case counts begin to drop. And we're seeing that this is really a great thing for the COVID-19. And people seem to think, we're making a difference. We're flattening the curve. Do you remember that? We're flattening the curve. Wonderful. Okay, we're going to see our way out of this thing. But then what happens? We have a confluence of many factors, and the case counts begin to rise. Why is that? The start of the summer season. People need to go on vacation, all right? And there's also, we have to get the economy rolling again, need to restart, get back to work. Humans, basically, fundamentally, are social animals. We need to get back together. We need to do the summer vacation. The beach is calling us all. And we have seen, personally, I've seen this too. The state of Missouri, we had this large recreational area in the middle of the state called the Lake of the Ozarks, where the bars and the boating just had this primeval call to get people together. And basically, that people resist the recommendation to social distance themselves in spite of the altruistic intents of the mitigation efforts. And what happened was that we just had this rise in cases over the summertime. And I saw this article in the Philadelphia newspaper where they surveyed young people this summer and why they didn't any longer observe safe precautions. And the comments were telling. The young people say, we like to do what we want to do. We want to get back to normal. We're all fine. Don't worry about it. I mean, we feel great. And the last one, I'm ready to go to a movie theater that's packed. I'm ready to go to a mall. Everyone around us has probably developed immunity. Okay. But as of June 21st, about 50% of the COVID-19 cases in Philadelphia were under the age of 34. And that continues. It's as though we can't get ourselves to retain this level of protection within the community. We have to go out and be ourselves again. And I get that, right? I get that. We can only stay inside the house. We can only get on the mask, which is uncomfortable. It's hot, fogs up our glasses. I understand that, but we just have to make sure that we can protect ourselves, our community, longer than 6 months. So the great summer surge continues, but we have to keep in mind this is not a second wave. If we read back to the great influenza of 1918, they had waves, but this is not a wave. This is just a surge. California, Arizona, Texas, Florida had huge surges. Those are states that were popular with travelers, right? And the demographics for those states are older and younger residents because younger people are going there for vacations. And why is it important that there's younger people going there? Because the younger people are just as susceptible as the older people to obtaining the disease, and they can spread it. They just may be asymptomatic, and they can pass it to anybody else, especially their older grandparents or parents. And then we have deaths that may occur from that. But it's important that the states do not consider rolling back the control measures again. Nobody's going to shut down. Nobody's going to say you have to have masks. In fact, the bars are not going to close, but they're going to say we can remain open if we sell food. So in Jacksonville, if you buy a pretzel for 50 cents, you can stay open and buy liquor. So the laboratories, hospitals, emergency responders, all of us in this community of providing for tests and medical care, we have to buckle up on this because guess what? It's Groundhog Day again, where we lost supplies early. We got a supply chain back. Now we're running out of things again, except this time it's not swabs and media. It's the stuff that we need to run the tests. not get the collections done. It's the stuff to run the test. We in the lab community call these things the plastics. These are the pipette tips. These are the trays that you pipette the material, the samples into, that you then put into the instruments to perform the test. These things became, and still are, critically short around the country. So what we have to do is that we have to call our partners at HHS, Health and Human Services, or CDC, and say, look, Missouri is a red state now, red being a bad state for case counts, and say that we have a 2 or 3 day supply left of our plastics from this company called whatever company it is, A, B, C, or D. Can you help us? And so the liaisons that we have at CDC will try to push our orders to the head of the line, and we will get another 6 day supply of plastics. And if that doesn't work, then we may have to call our senators in Washington and have them get in the queue to help us out. So these things are really important, because without the plastics, the instruments sit idle. We can't test. And it's the same holds true for our commercial labs. When they can't get the plastics, they call me, Bill Whitmar. And Michelle will say, Bill, I can't get my plastics. Can you help me out? So they send me their PO number, their purchase order number. I call the CDC person, and then they get their order pushed up to the head of the line too. So it's, again, this is a different role for the State Public Health Laboratory and the laboratory director. I don't handle just my own stuff anymore. I handle the stuff for all the commercial and academic labs throughout the state of Missouri. The pandemic has changed everybody's role throughout the nation. So throughout August and into September now, we're surging again to new heights. Schools now must open. It's not just the businesses in the summer that must open. It's the schools must open. So now the case counts are again soaring, and we're having very high positivity rates. And where is this happening? In those cities and counties where the universities are. And in Missouri, it's up to 60% positivity rates in some of these cities and counties. Well, anything over 10% is what we call pretty darn bad in public health, right? Really darn bad. So some of these schools were having plans throughout the summer. We're going to open up. Here's what we're going to do. When they get above 10%, or 10 cases, whatever the case may be, then we're going to think about going virtual again. Well, some of these schools now had been closed before they even were open again because of the high case counts. Now, realizing that the situation is worsening, the federal government now responds not by getting swabs and media and blah, blah, blah. Now they're getting into the business of providing testing, the testing kits, the testing instruments. Now it's the testing cards, and this is antigen testing. So they're delivering thousands of testing instruments to nursing homes and millions of antigen testing cards to schools and masks to schools as well. So the little device on the left is the Abbott ID Now, which is a device that tests. It's actually like a PCR device, and we've got dozens and hundreds of these in the state of Missouri. It's a 15-minute to a negative or a 5-minute to a positive device, and they really are pushing this type of quick, rapid test. And at the bottom right is the antigen card, and they're pushing this out to schools. And it's you drop a sample into that card, and it's really operates like a pregnancy test, where you get a result in a few minutes. What's problematic about this is that there's no way to report these tests no easy way to report these tests back to the health department. So when you have positives or the negatives, especially, how does the health department know and the federal government know how many things you have in the state of Missouri or state of North Dakota? How many negatives were there? How many tests did you actually run? Because there's no easy way. There's no electronic way to report those tests. Okay, so currently, the testing numbers seem to be stabilizing in general, or maybe even declining in some places. And there's some speculation about why this is. The students of higher ed may not be seeking, I'm not talking about you guys in Westminster now, may not be seeking testing due to the quarantine or isolation policies or other penalties that may be happening in some universities. Additionally, there's some workplace policies that are in place where if you are reporting positive, you only have to leave work for 10 or 14 days, but there's also, you have to have 2 negative tests over the course of 14 days too. That's problematic for people, right? You can't, for a PCR test, you may not get a negative for maybe upwards of 40 days because of the viral particles, even though you're not infectious, remain in your body for a long time. Also, the invasive collections are hindering some testing efforts. I don't know how many participants there are today that have had a nasal pharyngeal swab, but that's a painful process. Once you have one of those, you're likely not to go back for another one. So that's why we're investigating self-collection with saliva or just a nasal swab that doesn't go nearly as far up into your cerebellum or your cerebrum or whatever kind of cranial cavity you may have. Also, the case counts may be attenuating in some spots, but continuing in some others, depending on what sort of industry you may have. So those industries that I'm talking about are the food processing plants. Those things continue to climb, especially in the Midwest. And here's the paradoxical statement at the bottom. The state labs, like ours in Missouri, are utilizing higher throughput instrumentation. So while the commercial labs may be experiencing a lower caseload, the state labs are experiencing a higher caseload because now we are testing state employees more. We're testing sentinels, testing for prisons and maybe other schools and things like that. So commercial labs may be going down in volume, and state health labs are going up. This is a little graphic from Johns Hopkins University, which shows as of 9/8/20 what the testing situation is like. So the red is decreasing in states, the green is increasing in some states. Just a short little graphic. This is for testing, and this is the case count. It's a little hard to see, I'm sorry for that. Again, just a short little graphic that shows the case count situations in various states. And this shows for you the case counts in Missouri. As you see, once summer starts, we had an explosive case count, and it didn't really go down at all. Still not going down. And this one is really interesting. This is the cohorts between the other ages, all the other ages, which is the gray line, and the 18 to 24, which is the college age demographic. So as you can see, we have, I can't really see this because of the, hold on a second. There we go. So ignore the last downward trend there at the very right side of the graph, because that means that the records haven't yet been entered into this. But we see a great spike here at Labor Day for all the college age kids here in the blue line. That's serious. Oops, sorry, hit the wrong one. So that's a serious uptick. Once the college starts and once Labor Day starts, you see a very big uptick in college individuals. And I misrepresented this, I'm sorry. So the yellow line at the bottom is the high school age kids. So it's not directly related to the age of the children or of the young folks. It's related to where they are at, college or high or not. So this is the last part of this. I get this all the time. Is this really serious? Is this really a thing? Is this a hoax? Well, let me tell you, globally, we've had 800, well, let's say 900,000 deaths as of 9/8/2020. And in the United States, well, globally, let's say upwards of 650,000 flu deaths last year. So yeah, I'd say it's pretty serious. In the US, we're approaching 200,000 deaths in 8 months. Now for a year, last year, we had in all cancer deaths, it was 600,000. So you can gauge for yourself whether or not you think this is serious. And we are as of a couple of weeks ago, 6,300,000 cases in the United States for COVID-19, and we're not really assessing the longer term effects of this disease at this point in time, but we do know that there's damage to the heart muscles, we're damage to the alveoli, the strokes and seizures from blood clots and chronic fatigue syndrome, and probably innumerable other longer term effects of this disease other than, obviously the death, right? So this is something that we really need to take seriously. It's just something that we can't just say it's a hoax. We can't just say it's the common cold or the flu or whatever else has been attributed to this disease. We shouldn't just do that. And why didn't we do better? We've all had pandemic flu plans at the federal, state level, and this thing is just really a bit different in different ways. But the three things that were really different, obviously the political aspect we didn't consider in our pandemic plans, especially because this was an election year. The societal will against mitigation efforts, maybe the political aspect had something to do with the societal will, and obviously the economics, that issue that held sway over some of the public health interventions. Those three aspects really had something to do with this. And then let's also keep in mind that in the end, it's not important to look at one intervention, adopt it perfectly, and think it's going to be the silver bullet to end this pandemic. I have seen time and time again during this response that our leaders will say, this is the silver bullet. This is the one thing that we need to do. And how many times have I heard the term game changer? If I hear that one more time, I think I'm just gonna lose my breakfast over that term game changer. There's not a game changer to ending this pandemic. There's not going to be one. Please stop saying that. We need to do a number of different public health mitigation efforts simultaneously. And let's not think that we have to do them perfectly. Let's do them well enough, and that they'll be utilized to stop the spread sufficiently over time. Let's not think that we're going to do this for a 3-month period of time and it's going to be over. So the one overarching failure was that the traditional public health mitigations were not adopted or implemented fully. And it's not we didn't have the right tools, it's that we didn't take them out of the toolbox. Our leadership did not think these 3 bullet points over fully, I think. And so we need to think that, and this is probably part of this symposium, is that leadership is so important that we need to look to our leaders and think that they need to look below them and to look at public health, look at the medical teams, look at other portions of their leadership teams, and adopt what is being told to them. And I don't know if that has always been the case during this pandemic response. So what do we have in front of us? I don't think it's this. At the left is a New York City public health morgue in a semi-truck, and the other 2 are from Brazil. And the one on the top right is something that is really striking. And now they're assigning people that don't wear masks to go out into the countryside and dig graves for people that are awaiting a grave. I don't think it's that we have to look forward to, but certainly if we don't take a hard look at what we're doing at this point in time and continue down a certain wrong path, this is a possibility. But we do have the right tools at our disposal, and we can prevent something like that. So I think I've gone on probably too long. This is our friend the pangolin, who's been attributed to starting all this thing back in China. But I appreciate your time, and I hope that you've taken something away from this that can start a conversation amongst yourselves. So thank you very much.
Thank you so much, Bill. This seems complicated. I felt that it was pretty complex before, and I feel like you really shed a lot of light on the testing procedures that many of us weren't aware of. And I also truly appreciate your passion towards leadership and methods that we should take in place to help this disease continue to decline in our country. We do have a few questions, and I encourage those of you watching to continue to use the chat feature if you would like to continue to ask questions. We're watching that pretty closely. One of the first questions we had was from Ashley Bird of Missouri Net Radio. And she's asking, since most of the lab testing is done outside of the state lab, including many private labs, how are those overseen by the state lab?
That's a good question, Ashley. Thank you for asking it. Within the state of Missouri, we have in the Department of Health and Senior Services, a division called the Division of Regulation and Licensure. And they have a CLIA, or Clinical Laboratory Improvement Amendment Unit. And they are the ones responsible for inspecting the commercial laboratories within the state of Missouri. And they conduct audits of those laboratories to ensure compliance with the many different regulations in the state of Missouri.
Okay, thank you for that clarification. I think that there's a lot of different testing types going on, so it makes it a little bit more confusing.
Yes.
Speaking of the majority of the different testing going on, could you elaborate? We have a question from Maggie Sherman that's asking, is there a method of testing that's more accurate than others? You had mentioned the nasal versus the throat versus some of these other things that are being tested.
So if the question is about collection versus testing, so the collection that we would prefer is nasal pharyngeal, because that gets a deeper sample. But I know that that's the more invasive and more uncomfortable way of collection for a sample. But I do know that more is happening with the nasal collection these days, which involves a shorter swab and less invasive collection these days. So, and then it gets a sufficient swabbing of the individual, but they do both nares these days using the same swab. So, and that's very sufficient. And as far as the testing goes, using that swab, the PCR is the most accurate at this point in time.
Okay, with the nasal swabs, you had mentioned that there was a manufacturing company that sent swabs to the state lab that were cotton, and then they were saying that they were synthetic. Kevin Schuler asked, was that ever verified, and are those swabs being utilized, or are they just for backup in case we run out of supplies?
Yeah, that was verified that they were not cotton. They had sent a certified letter, and it was, excuse me, verified by the FDA in Washington, the Food and Drug Administration, that they were not cotton. But because they are not individually wrapped, and we can't verify that they are sterile, we do not use them. We don't send them out. And we do have a few pallets of those in our warehouse. And unless there's an absolute critical shortage of other swabs, we will not use them. And I'll tell you at this point in time that we are receiving tens of thousands of swabs that are sufficient and suitable every week from the federal government. And so I don't foresee a time that we'll utilize those, in quotes, cotton swabs, even though they're not cotton.
Great. We have another question on the chat here. A lot of the information has happened every month, so we continue to get more information through the media. How do you feel that the media has played into our understanding of COVID, along with misinformation versus verified information?
To put it bluntly, I think there's a gradation in the media presentation of what's been going on. I think there's misinformation and there's good information. So I think what you need to do is verify your sources and look at your sources. If you're getting your information from Facebook or social media about COVID-19, please stop. Honestly, please stop, because there is no way to verify your source with social media. Similarly, if whatever you're doing for your consumption of news with COVID-19, please go to the CDC and get your source of information from them. That's where you're going to get the most accurate, reliable source of information. Or in the case of Missouri, the Department of Health and Senior Services. We are vetting that information through CDC, through our own sources. So, and ourselves, of course, are very credible. So that's where I would get my sources of information for COVID-19.
I really appreciate that you're here today. We continue to have a lot of the chat questions. I feel like there is still a lot of misinformation and complicated understanding. And I know that having you here is going to help kind of clear up a lot of issues along with continuing us to move forward. Another question is, for those that continue to suffer long-term problems, what can be done for them? I think there's some information depending on what's going on, but there's still some unclear long-term results. Do they continue to see the doctor, or what kinds of things are we hopeful for?
Yeah, that's a good question. I wish I could offer a better answer. I'm not a physician, but that brings up another point. That one thing we were doing as a non-traditional role in our state public health laboratory is to receive and distribute the remdesivir, the drug that was offered as a way to lessen the effects of COVID-19 on patients that were hospitalized and on ventilators. That drug was really instrumental in lessening the effects of COVID-19 on patients that were otherwise, that may have been a fatal outcome for some of these patients. So with the administration of that drug, initially it was 11 vials per patient course, and then they were able to reduce it to a 5 or 6 vial administration. Those patients came off the ventilator within a few days with the administration of that drug. So our lab was very instrumental in the administration or the distribution of that drug. So the remdesivir, I think, if it can be administered, and that's just from my limited experience in this for that question, was very helpful for those patients long term.
Okay, thank you for kind of going outside of your normal realm there to explain that. This might be another question that kind of goes along those lines, but since we are talking to a lot of college students that are living in communal housing, do you have any specific recommendations for other precautions that students should be taking to help lessen their chances or lessen the severity?
Yeah, it's not that I was a college student, right? I don't know how I would have handled this back in the day, right? I like to have fun too. So I can't imagine what it would be like these days, but I think it's pretty simple, but it's easy for me to say this, right? It's you social distance, you wear the mask, and you try not to go out and do the things that can get you infected, right? To be exposed to those things that are going to happen as a course of normal business for a college student. So what we do in our household is that we wear the mask when we go out and do our shopping or something like that. In fact, we don't even do normal shopping anymore. We do the online shopping, and we have groceries brought out to the car. It's an adjustment to these pandemic times, and I think that people can make that adjustment. But are they willing to make the adjustments, and are they willing to stick to it over a longer period of time, as opposed to just a couple of weeks or a couple of months? I know that this is inconvenient. I know college is fun. I know what it's like. I've been to a bunch of them, right? But if it's meant to be that the community is safer for not just you as a student, or you as your sorority or fraternity mates, or your college professors, but your family back home, your grandparents and whatnot, think about what you need to do when you're at school. You may sacrifice some things. Wear the mask, hand sanitize, wash your hands, stay away from the pubs, or be outside more. If you need to take some time off to de-stress because of the upcoming examinations or whatnot, I mean, do that sort of thing out in the parks. Boy, I know it's going to be hard on you guys. This is going to be a generation that does things differently than the previous ones. But this is something that nobody else has had to go through since 1918. It's just going to have to be done, I'm sorry to say.
So as we take that response and kind of expand it, we have Professor Bruner from our campus asking, what about colder weather coming up? Is there any other concerns that you might have for the winter season coming near?
Yeah, I'm not happy about it. Right? Why is the flu such a problem in the wintertime? Because people come indoors, right, and they commingle more. They're not outside as much. So we in in the laboratories are not looking forward to this upcoming fall and winter and early spring. There's a confluence, again, I use the word confluence a couple times today, of COVID and the flu coming together. So we've increased our testing capacity, and we're coming up with new assays. That's a combination or a multiplex assay to do COVID-19 and flu A and B with the same test. That way we don't have to run separately a flu assay and a COVID-19 assay, because we anticipate this is going to be a horrible, horrible fall and winter because there's going to be people with flu and COVID-19 at the same time, and the symptoms are going to be essentially the same. How do we know? How does a clinician know whether they have flu or COVID-19? Yeah, the fall and winter is a bad time for respiratory diseases because people don't get outside much and they all huddle together indoors. So yeah, the university administration should really be stressing the mask use, the sanitation practices that go on within their university systems.
And kind of continuing on that line, do you know of any updates that you have for cures or vaccines? Like what information are you getting regarding that front?
Yeah, so the vaccine distribution systems are being worked on as we speak, and at a very rudimentary level. There may be different distribution levels. Maybe as many as 3 or 4 over the next 9 months or so, and they're working out who or what sort of populations will be getting the vaccine first, second, and third, or fourth. And I can't tell you because I haven't been a part of those discussions yet, because these are at very high levels at the state and federal government as to who will get those vaccines first. But they're working on it right now, and but when those plans do come to fruition at a more definitive state, then everybody will find out.
Okay. Thank you so much. I think we have one more question to kind of end with today, and it comes from Professor Langton on campus. And you had an article in the Fulton Sun recently that mentioned the need for a coherent plan. That might be a good elaboration for us to end on. Can you elaborate on a coherent plan that you feel like needs to take place for this virus?
Yeah, that's been a sticking point from me and the Association for Public Health Labs for many months. Like I said, it seems to be the way it works is that someone is like walking down a sidewalk, and they see a shiny nickel on the sidewalk, and they go, "Here, look at this shiny object, and this is going to be what's going to get me down the road for the next 6-8 months." And then they take 2 more steps, and to their right is another shiny object, and they pick that one up. Well, this is going to be what it gets me down the road for the next 6-8 months. And there's a staggering back and forth down this sidewalk of what shiny object is going to fix the problem next, and that is not a strategic outlook or strategic plan to address this pandemic. There just has not been one since the onset of this pandemic. And we all know that there was one. There was a pandemic plan and has been since 2002 to address an avian influenza outbreak and pandemic. And it was just not utilized or maintained or updated or dusted off. And an outbreak and a pandemic, regardless of the agent being a virus or bacteria or whatever, is irregardless. You address it in the same manner, and you just have to adapt it for a scope or a magnitude. But the same thing sort of happened, right? You have a strategic national stockpile, and you distribute the drugs to wherever you need it to go, and you have these certain people that can address certain problems. You have logistical problems, and you have administration problems, and you have all these people come together, and they all exist. And so all you have to do is assign tasks to the certain problems. That was never really enacted during this pandemic at the higher levels of the government. And so we at APHL tried to get that going. But there was just so many, I think, so many problems that nobody had the time or took the time to just step back, right? And say, let's take a breath and let's see what we really need to do long term to address this pandemic, as opposed to just saying, okay, we got this, now we got this, now we got this. So that was our beef with how this response unfolded, that there was just seemed to be no strategic plan to address it.
Okay, I like ending on that note. So being more proactive instead of continuing to be reactive. I know that we continue to learn and adapt as we continue past this COVID-19 challenges that we have. Thank you so much for your time today. I know that I learned a lot from you and still feel pretty overwhelmed. I know that there's still more down the road that we're going to have to deal with, but I'm hoping that our audience today will continue to take this virus seriously and continue to make the proper precautions as we kind of move through the rest of this year. Lastly, but not leastly, I just wanted to thank you all so much for your time today, but also give a shout out to our IT staff. As Mr. Whitmar has kind of pulled back the curtain on COVID-19 testing, I've had a little glimpse into Symposium behind the curtain, and I tell you, there's been a big team that has gone to work here, not only our IT staff, but also so many other Symposium team members to put this together. So I'm so happy that our session today went off without a hitch, and we had some good, I think, responses from the chat audience, and I hope that you all continue to engage with the symposium. We do have a little break for lunch, and the sessions begin. Another plenary session starts at 1:15 today. I think there's still time to log on and join that session, but take a little break and come back and regroup for more learning today. And thank you so much to Bill Whitmar, and you guys have a good rest of your day.
Thank you very much. I enjoyed it immensely.
Thank you.